In CLL, there are 4 major monoclonal antibodies that we use. So for the first one is rituximab, which is our oldest antibody that folks are all familiar with, the infusion reactions during the infusions that get better with time, and then not a whole host of significant long-term effects afterwards. Certainly patients can have cytopenias and minor side effects afterwards, but typically they're completely infusion related. Unlike some of our newer agents such as alemtuzumab or Campath, which has really fallen out of favor but is still used, as well as ofatumumab, where the infusion issues are different. They have more infusion reactions and the infection risks are higher than rituximab. Whereas we started with rituximab where it was all about infusion reactions, some of our newer monoclonals do have higher incidences of infection and infusion reactions. And then we also now have obinutuzumab, which is given along with chlorambucil for initial therapy. That also is hard to peel out what's just the chlorambucil and what's the obinutuzumab because you're giving a chemotherapy agent. And that typically changes the side effect profile as well. Really, the most important thing now that we're getting more and more monoclonals for CLL is for the advanced practitioner to really understand the package insert, the dosing. Do you use steroids? Do you not use steroids? Do you use, what do you pre-medicate with? There are some differences. There are titration differences. There are schedule differences. It is important for the advanced practitioner not to try to memorize all of the details about all of these drugs, but to go and have good resources and know where to go to look for information to be able to safely dose and manage side effects in this patient population.